Palliative care is really an old-fashioned term, I feel, really. It's, people will be talking about palliative care now since the 60s, so about almost 50 years. And it was started because people with, really at the very end of their lives, people weren't doing so well in the current medical model. So this whole idea of palliative care started. But it sort of moved on a bit from there, and it's now more of a supportive care structure. We depend a lot on other groups, like your group, and allied health groups and community groups, and I suppose palliative and supportive care is more like we sort of coordinate care. I always work with other people. I work with nurses, I work with allied health, occupational therapists, physiotherapists, social workers, psychologists, counsellors. We like to talk to people, talk to families, and help in whatever way we can do that. Over here at the Mater, I sit in a CBL clinic with the family. We have a long consultation, and then either follow up while patients are still having their chemotherapy, and after they have stopped having chemotherapy, no longer coming to the hospital, we would refer our patients to a community palliative care service in Brisbane, and that's usually run through St Vincent's Hospital or Queensland Health have palliative care services of various usage really in Brisbane and the area. What we do in palliative care, we see patients. I always ask routine questions. I ask about their symptoms, I ask how people are getting on, I ask about how they're managing at home, I ask about how the carers, if there are any carers involved. We have patients with wonderful carers and spouses and children. We also have a lot of people who really have very limited resources. Depending on the resources or care that they have, we can then refer on to support through domiciliary nursing agencies like Blue Care or Auscare or Silver Chain. What we try and do, Palcare, we try and do symptom management and support, but also if you're at home anxious and fearful and worried and some friction, and that makes everything worse. So we'd like to, as part of general management of people, we'd like to relieve or reduce anxiety and fears as much as we can. And we do that by just talking to people in education and having some sort of contact.
If I was to, and I am having just some issues in relation to my medication, and I'm seeing my medical oncologist on a weekly basis, but I feel like I'm not kind of getting any better or things aren't changing, would that be a service that I could possibly go and see instead of, or as well as, or get some other advice or other opinions on what might be best for me?
If it's medical related, if it's drug related, that specialist would be the one talking about that. But often you're going into the clinics and they're very short, and they're you don't want to bother them, the doctor's too busy, etc., etc. I hear that all the time. I think one of our big things that we've got is some time. Palliative care just can offer some time for people. When you speak to medical oncologists, they often say things like, "Oh, you don't need that yet. Don't worry about that." And, "Oh, no, it's fine." And they're fearful that if you involve palliative care, the patients are going to lose hope and give up or something like that, which I've never seen that happen, and also the studies, that research shows that does not happen at all. So it's just looking at something clearly. It's like taking your glasses off and cleaning them to see things clearly for a while. And it doesn't change anything. The talking and the expressing and the writing down and asking questions, it just seems to clear the air somehow.
Is there like a national line you could read? Like, is there any helplines or anything like to get that sort of preliminary information?
There is a palliative care helpline.
I thought that was a Queensland-wide telephone.
There is one. Yeah, there is one. I'm not sure how if it's going or not at the moment. I'm sorry.
You talk to GP or an oncologist.
Or your GP or oncologist, yeah.
Okay, thank you.
But I think it's just mentioning it and just saying you have concerns. And it's okay to talk to the doctors, really. It's okay to go and say, stop, excuse me, I've got a couple of things I want to talk about today. Could you answer these questions, please? Even though they're very busy, they're not that busy, They can just say, okay, this is what I'm concerned about, and do that. It's okay to interrupt and, slow the stream a little.
When you say early intervention, what do you actually mean by that? How early are we talking about? I mean, I know you said stage 4,
Yep.
but we can be stage 4 for, well, a lot of us here, 3 years, or and you just don't know when early intervention would be.
Stage 4 is really metastatic disease, where it's the cancer has spread from the primary site, and I think as a starting point, I think stage 4 disease of any sort will be okay. And as you say, a lot of people are stage 4, and and a lot of people who have working and doing all sorts of stuff, and I know that. And perhaps they may not really need us, but I think that should be offered in a way. And often you could have a contact. And I know at St Vincent's, where I worked before, we would go and see some people. And after a while, you realise we're not really need to do anything much. So we say, oh well, we don't need to see you regularly. Here's the number. You can contact us. We will quickly come involved any time in the future.
Hi, Dr. Russell. I'd like you to talk. I think what will help women here too is to hear palliative care's role with pain and pain management, because often that's something too that takes quite a bit of time and tweaking for women to find the right management for pain.
I think that's where healthcare started, was pain management. People weren't looked after that very well, and a lot of those days, it started in the 60s, and really all we had in those days was morphine, and it was given regularly. For pain management, we would like to get why is the pain there? Where's it coming from? It's not just pain. Is it from, often it's breast cancer particularly, you get bone metastases, and they're painful. And so we see, where is the pain? We would image that site and do an X-ray, and often that sort of pain responds very well to something local, like some radiotherapy, something like that. That works really well. Sometimes it's generalised pain or more widespread pain. You need something stronger. We always use the least toxic, the least drug with side effects as possible. Well, the current principle for pain relief is to have something regularly for pain. I think if pain isn't treated or addressed, it sort of builds up, and it sort of works on you a bit, pain. It sort of nags at you. It sort of becomes more and more insistent. I think it's a bit like a child that you're ignoring, and they just get louder and louder. And I like to recognise it and treat it early, really. And either, if it's not too bad, it's something simple. If not, we use something regular, and that's often we use long-acting tablets or patches and things we use these days as well. I think if you've got a plan and know what to do, people often can put up with things easier if they know, well, I'll do this if it gets any worse. But if you've left without anything, I think that's very difficult. And also you use one medication and you start getting side effects from that, you can change over to something else. The morphine drugs, which we use a lot, in the higher doses, do tend to sometimes get a bit cloudy, and people don't like that feeling. We would swap over to something else. I think the patches are very good if they work. They don't always work. People seem to like those because that's a patch that you have pain and you replace every 3 days or every 7 days, depending on the type of patch.
When it comes to radiotherapy and pain,
Yeah.
can you only have radiotherapy so many times to a certain area?
Yeah.
That's
The problem is that if you give too much to that area, the skin breaks down over the top. Or if there's any underlying structures underneath that, like nerves or spinal cord or bowel or lungs or heart, it sort of has a limit. But the radiotherapy doctors know that, actually, and they can often modify the doses or treat it from a different way sometimes, or they're getting cleverer and cleverer and cleverer at that, and I think radiotherapy is very useful. I think the figures are that 80% of people get very good or some pain relief with radiotherapy. Only about 20% don't get much pain relief.
I think, in my experience with some other chronic disease, it's good to have, whether it's with palliative care or somewhere else, that coordinating conversation, because, and I don't criticise them, a medical oncologist with 30 people sitting out their door have to get those 30 people assessed and get them off and on to the treatment of the day and those kind of things. They don't mean to be in a hurry, they are, and we respond to that by, I'll ask that next time, or I'll, you know. And I think having a space to then go back and say, yep, I got my treatment today and I've got my scans ordered and all that kind of stuff, but particularly with medication and pain relief, or maybe getting someone to help you realise there's a lifestyle modification or something like that, is a space that in the craziness we don't look for, because you're also, if you're not well, you're not thinking clearly yourself, and getting someone to help you with that is, I think, invaluable. So thank you.
It's time. There is nothing whatsoever rushed, and I've been seeing the counsellor there because you know, it's a group thing, and because it's more to do with living your life now with that support behind you, because pain is a part of my life quite dramatically.
Sometimes we can be really great, and other times perhaps can't offer much, but we can always offer something certain as that. I wish that was better funded as well. You know, the cost of the medical oncology drugs, which is sort of out of the world, you know, all we need are things like, you know, walkers and toilet frames and, you know, a nurse to come twice a week. That would make a huge difference to people. And some people can afford that, not people can't. But it's a principle really of care, and a lot of GPs do a really good job, you know. And what it is, it's a principle of being honest, being realistic, and giving people some time, and addressing really simple things like pain and breathlessness and nausea, all those things that interfere with things. It's saying, how are you going? Do you need some help? You know, and organising some home help and some nurses sometimes, or just someone to talk with. A lot of it is just basic stuff, really.
I mean, you see people at the end of their life, probably most days of your working life, I suppose. Yeah. What's your personal strategy for not getting upset or distressed about those deaths?
Is that just about always I can sort of help people in some way, and so for me I get this sort of feeling, oh, I've done something today, you know. It's a background thing. I don't think about every person like that, I suppose, but I do have that feeling generally that I'm doing an okay thing. And I think all the staff that I work with, they're all very supportive and feel the same sort of way. So it's a nice environment for me to work. People don't really understand that, but it's actually a good environment to work in, because we sort of feel, I think, that we're doing something. And I suppose, you know, it's different. I'm a professional person, so my professional life, my personal life, and it's different, really. I think doctors do get a bit hardened and a bit sort of cynical, and hopefully I won't get too hardened or cynical, but I don't think I do. And you need to talk to people and you need to debrief a bit.
I think palliative care, it's a bit like people being in a group, like you said, Lorraine. It's not for everyone, but you know, I think our experience is when people can talk and think about their worst fears, it's not so frightening anymore. One woman who's in one of our DVDs, Fran, and whose husband was the partner in the Partners DVD that we wrote, I think they had palliative care involved for some long time towards the end of her illness, and she decided she wanted to die at home, and he was with her, and they had nurses coming in, and they had family on roster, and she used to speak about in advance saying that she'd seen women die, what she called in a state of grace, which she meant not being frightened, but being ready. And you know, I think it can make a huge difference to people to feel that sort of safety and support around them.
I think that knowing that there's other people out there, and there are people you can call, and then there are people who perhaps understand where you're up to, and listen to your symptoms and validate the symptoms and accept you. I think that's important. Yeah. So palliative care, I think, is a scary word. I know that, which it wasn't. I think it's just a form of care. I think we should be involved more earlier in some way. It doesn't have to be a palliative care service, but just the whole idea of being of care is important. I think treating symptoms early is important, and calling for help and discussing things is necessary as well.
And the thing that I've found wonderful is that they're really treated like they still matter. And that is so, so important. I mean, I remember a girlfriend of mine, Colleen, and she was in palliative care at St Vincent's, and I'd gone in to see her, and she had a hairdresser coming to cut her hair. You know, I just thought that was beautiful, you know, because her hair was too long and she didn't want it long. And it was only a matter of a week before we lost her, but I thought, wow, how neat is that?